Good afternoon, dear colleagues. It's really a privilege and an honor to take part of this meeting. I'd like to thanks for the organization, particularly Dr. Wang, for the wonderful invitation. It's my first time in China too, and it's really wonderful to be here. And my talk today is about the challenges of starting a TAVI program in Brazil, primarily focus on acute valvular syndromes. These are my disclosures. As you will all know, TAVI has become the standard treatment for aortic stenosis for most categories of surgical risk patients. Since 2002, when the treatment was just beginning, several trials compared TAVI with surgical approaches or clinical management, showing that TAVI was at least equivalent or superior to the other treatments, and so it became the standard treatment. This is only two of the trials regarding the TAVI comparison with surgical treatment for low-risk patients that made this therapy incorporated in several guidelines. Since the tremendous results from observed in clinical trials, the registries could show us what we could expect, a raising in the numbers of TAVI treatments around the world, becoming the preferential treatment compared to surgery in terms of numbers since 2018 in developed countries, but also being incorporated in emerging economies. When you look at the guidelines from different parts of the world, from America, Asia, and Europe, TAVI has been considered the preferred treatment for older patients, but we have a gray zone that is pushing to younger population the adoption of the therapy. Today, many patients above 70 years are considered TAVI candidates, but we see a progressive decrease in the reference age. In Brazil, we have this procedure incorporated in the public system only 2 years ago. We have it in the private system for a long time, but most of the population relies on the public system, so it's been a challenge to incorporate the procedure for this part of the population. This is some of the factors that influence our decision regarding TAVI indication, and you see that we are pushing the limits regarding age and also anatomical complexity. So we see an increase in the population referred for TAVI during the last years. We still have some open questions in this topic, mostly regarding expanding indications, but also how to reduce complications, how to improve durability and compatibility with reduced TAVR, and also a tailored approach, how to select the best device for each patient. But I would say that the most challenging topic is certainly how to provide access to the therapy from different parts of the world, particularly in emerging economies. The fact is that we have a bigger and bigger population of patients referred for TAVI, and most of the patients with aortic stenosis are underdiagnosed. And as the population become older, it is expected that we still have an even higher number of patients referred to the therapy, creating an unproportion between the demand for TAVI and the system capacity to treat these patients. So I would say that the challenges for starting and scaling the TAVI program would pass through the raising prevalence of aortic stenosis, the underdiagnosis by the limited capability of diagnostics, including clinical evaluation and echo, but also a limited infrastructure for the specialized centers that have CT and CAT lab that are essential for the indication of the procedures, and overload hospitals with long waiting lists for those centers that provide the procedure. and also some problems regarding reimbursement of these centers, demanding a procedure efficiency to keep the system viable in terms, financial terms. This is the regular pyramid representing the proportion of patients referred for TAVI, and most are elective patients in a healthcare system well equipped, and only a few proportion of the patients are referred in acute decompensation. And I would say that in a system, in an overload system, the proportion are completely different. Since we have a long wait list, most of the potentially elective patients become acute decompensated patients, stressing the system to provide the care in a much more difficult situation. We know that acute valve syndromes carries a worse prognosis, not only in the procedure itself, but also in the follow-up of 1 and 2 years. And also, we have a higher cost in terms of length of stay and hospitalization that stress even more the system. The cause of this is that most of the patients that are diagnosed in acute decompensation have triggers which are heterogeneous, including infection, acute coronary syndrome, anemia, arrhythmia, congestion, and which influence the way we should evaluate these patients and treat them. And some of them present in a critical situation in which we are really facing an emergency in terms of time to action, like cardiogenic shock, but other patients are in a subcritical situation in which the major challenge is what is the best time to investigate this patient and to treat them. Should we wait until a stabilized situation to proceed with TAVR, or should we act early, even in some degree of decompensation? When you look at the data, the patients referred for urgent TAVI versus balloon valvuloplasty in the context of cardiogenic shock, we see that we don't have much robust data, but these few studies, 6 studies put together in 21,000 patients, mainly observational and retrospective data, show a decrease in mortality as you proceed directly to urgent TAVI in comparison to balloon aortic valvuloplasty as a bridge for a definitive treatment later. But in fact, you know that this kind of result could be achieved only for very experienced centers and tertiary centers, which are probably represented in this data, and that we have to take a look at the local capability in order to select the best strategy, whether balloon or TAVI, urgent TAVI, putting into perspective several aspects, particularly the time to discompensation and the triggers that bring the patient to a critical condition. But I would spend more time talking about the subcritical aortic valve because it's a larger group, and because we have some doubts regarding the best way to go, and it would probably impact even more in terms of the proportion of patients in this situation. This is like an intermediate group, not emergency nor elective. They usually are hospitalized due to some decompensated trigger, and we have to decide whether we should start the workup for TAVI in the hospitalization in an unstable situation and proceed with the TAVR, or we have to, or if we would better decide to go to other strategies. When you look at this is only one data representing this type of patients, we see that proceeding with urgent TAVI in comparison to elective procedures is associated with increased mortality, not only in the procedure itself, but also in the landmark analysis after 30 days. And the main factor, the only factor that was related to 1 year mortality was the length of pre-TAVI hospitalization. So the longer the length of pre-TAVI hospitalization, the greater the mortality of the patients. So looking at the pathways of TAVI patients in acute decompensated AS, we have this but usually this kind of situation. In the top of the screen, you can see the elective procedure in which the workup was and the heart team discussion was done ambulatory, and then we have a waiting list time, and then the patient is admitted in the day of TAVI and stay only for 2 days with a minimalistic approach. And we have this situation with the patient is admitted in acute decompensation. During the hospitalization, we have to do the workup, which sometimes challenging because the patient has to do a angio CT and sometimes a coronary angiogram, a heart team discussion, and it sometimes needs time to stabilize the patient. And if you perform TAVI in the same hospitalization, we end up with a higher mortality and still a longer time of hospitalization after the procedure. So what can be done to avoid this situation? We have to consider the possibility of prioritizing this kind of patients and create some pathway that accelerate the evaluation and the discussion by the heart team, like a fast-track hospitalized TAVI, or we can like to stabilize the patient, give him some time out of the hospital so he can recover in terms of infection or in terms of avoiding the risk of delirium, which is frequent in this kind of population, and then bring him back after 3 or 4 weeks to do like an elective procedure. So these are the two approaches that perhaps could be combined to avoid the situation of long waiting time to the procedure. Because here, if the patient is critical but has no infection, we can and we have the system capable of doing this, we can do a fast track. And if the patient has some conditions that require longer time to recover, perhaps we could consider this approach of discharge the patient and bring him back to the TAVI procedure electively. This fast track approach has been considered in a paper, and compared with the standard approach, it resulted, of course, in a shorter time to TAVI and a shorter length of stay and decreased death and acute kidney injury. It requires a different CT protocol to low dose of contrast, a protected cath lab slot so that we can shadow the procedure in timely and minimalistic approach with early discharge, avoiding ICU hospitalization. And this kind of prioritization could be also interesting for elective patients. Simulations in the Canada system has shown that if you prioritize the high-risk patients, even ambulatory, giving them a shortened wait time list for 3 weeks, it resulted in 29% reduction in death, 23% reduction in hospitalization, and 38% reduction in urgent procedures. So this is definitely something that we should pay attention. We have to focus not only in the procedure itself, but also in strategies to wisely manage the waiting list of this procedure. I brought one illustrative case of fast track in our institution. This 86-year-old male presenting with progressive dyspnea in class 4. Interventional cardiology was called due to low flow, low gradient AS. This patient had already a diagnosis of moderate AS several years ago, lost follow-up with mean gradient of 30 at that time, a previous LADD SPCI in 2019, already with a pacemaker, and he was really dyspneic with congestive heart failure, as you can see, and also a new LV dysfunction, no anemia, a good kidney function. So we decided to quickly proceed to evaluation for TAVI, considering that perhaps was the main cause for this decompensation, but also we had to check the coronary. So we performed an urgent CT, finding a good anatomy for the procedure, no particularly worries. And then we brought the patient to the cath lab and performed an angiogram. You see a severe lesion in the left main, bifurcation in osteo-LAD with porcelain aorta. And then we decided to do it with TAVI procedure in an urgent fashion, where we implanted a balloon expandable device with good result. And after the implantation, we could provide a mechanical support to this patient with Impella, and then we could do the left main PCI, protected left main PCI. And the patient had a short length of stay, discharged after 48 hours, and after 9 months, a good recovery of LV function in class 1. So this is the type of case that if you act fast, you probably can help a lot to avoid complications. The fact is not only medical, it's certainly structural and logistical. Every patient with severe AS deserves a timely treatment, but the timing must match the physiology and the system capacity. This is the main idea that we have to leave. So we have to invest in diagnostic assess, infrastructure staffing, procurement issues, and manage financial sustainability. Also, it's important to have data management and governance. We have to monitor continuously door to TAVI time, length of stay, ICU utilization, complications, and outcomes at 30 days. It is important to have KPI dashboard and monthly morbidity and mortality meetings to provide transparency to the staff, demonstrate efficacy and improve pathways, but as important as improving procedure itself. So the key message I would say is that TAVI is now an established therapy across all surgical risk strata with consistent evidence of improved survival and quality of life. In many countries, there is a growing imbalance between the demand for TAVI and the system's capacity to deliver it. This mismatch determines how patient presents. This is important, with a predominance of acute decompensation rather than elective evaluations, as in the public systems in Brazil and other emerging healthcare settings. Acute valve syndromes emerge as a real-world manifestation of this imbalance, reflecting both clinical urgency but also systemic constraints. And improving pathways, resource allocation, and multidisciplinary coordination is essential to shift from reactive acute management toward planned, efficient, and equitable care. Bridging the gap between TAVI demand and health capacity is the key challenge ahead, transforming acute presentation into opportunities for timely, structural, and sustained intervention. Thank you very much.